much information there. As we know, that Secrecy has restarted their visit again, but they're doing a visit in a different way, because this time what they're trying to do, they are trying to do most of the visits online, and only one of the inspector probably would visit to the practice if it is needed to see something physically, whether it is an infection control or any other premises issues. They need to visit. They would only that time they will do it. So what CQC has done from spring, they have redesigned their services, and they have decided to do in a way so they don't disturb the practices too much. So can I have the next slide, please? Because they are doing a very flexible way. Not everybody going to get a visit, and not only that, not all visits will be same. So it's not like everybody will be looked into. So what exactly we'll do that? I'm just going to tell you that what exactly happening in Newham, because they have started in their own way. So in this visit, they will have an access to your computer for 3 to 4 days, and they will do their own searches. So can I have the next slide, please? Next slide. Okay, now look, what exactly we find in Newham, not only in Newham, in all the countries, the general practice are really doing very bad on these 4 regulations. So what I did, I just simplified the regulations, because you will see that when your letter comes, it will say that you have violated regulation 12, 13, 14, 15, whatever it is. It's very difficult to understand. So what I did, I only simplified that in the slide. So it's, say, for example, regulation 12 is self and treatment care. So what they're doing now, they're extensively seeing how you're conducting your video telephone consultations. And at the end of the my talk today, I will show you what exactly they're looking for. Then regulation 13 is safeguarding. They wanted to make sure during the pandemic you answered all the safeguarding questions, so nothing has gone to the net. So all the child protection issues been dealt. The regulation 15 also we are failing Newham quite a lot. This is about your premises fire safety and infection control. If you have moved to a new building, you definitely is going to get a visit now. If you have changed anything in your building, you might get a bit of a visit now. So regulation 15 is also our weak point. And the second weak point is regulation 17 about governance, that how you check people DBS, how is the doctors doing significant events. So this is another area we are not doing very well. The last one that we are having a problem is the regulation 18, that is called staffing. What I did in this slide, just simplified everything. So whenever the report comes, whenever somebody talks to you, you do understand where your shortfall is. Next slide, please. So as I said, that not everybody going to get the visits. So the people are going to visit. First category is the high risk, they call, is people are on special measure. Okay, so these are the people who are on special measure because they had 1 or 3 breach of regulations. Okay, the next thing people are going to visit it, the people who are on inadequate. That means they have 1 regulations breach, but then and that's to be fixed when the secrecy needs to come. Now this time they are going to focus on 3 main areas: safe, effective. Because remember, we couldn't do that much responsive and caring during the pandemic because our patient satisfaction, our patient participation group was not that active. So they will look for some evidence, but mainly they are worried about these 3 areas. Okay. As I said in the past, all the time, or my first 5 years about the CQC, whenever you got a CQC report, start from the last page. Your last page is your determining page. If your last page contains must improve, you must going to get a visit. That means it's a breach of regulations. Should improve, you haven't broken any regulation, but you have an area where units require improvement. And would improve is just the suggestions. So the people who have got the last report, they must look at their report, last report, to say if there is and must improve, they might get a visit within 6 months. And then if you got a visit, you must let me know. On behalf of NHC, I just wanted to tell everybody to reassure you I am the part of the pilot of the Secrecy new way of visiting, and I can reassure the practices that these visits are less stressful because most of the time you don't see anyone in your building. Only one day, one person comes for 3 to 4 hours. And the practices are reporting me, the practices that I did, that it is more comfortable and it's more tiring than before. So the feedback I'm getting is very good. So I don't really want it to too much worry the practices. On behalf of NHC, I can say that I will give you provide the service. We'll give the bit of management support. And the great news is the most important changes in this visit is online searches. And we have one pharmacist, she already working one of the practices. Now she's going to get more experience. Once you have received any kind of notification from Secrecy, remember, not all practice will be looked into the same thing. We are all different. Those kind of benchmarking visit is gone now. It's more tailor-made. It's only area where you need to improvement. So whenever you receive something, let us know. We have a team of help here, and we can reassure you a lot. As long as you can give enough notice, we'll come and help you. And it's not that tedious. It's more user-friendly. Only problem you have that you might not have the same visit as your next door. So please let me know when you receive any kind of visit. So any newly registered, like we are going to have one as an NHC for our 8 to 8 service, or if you move to a new building, obviously you're going to get a visit, and that will be a smaller visit because it will be only for the premises. So anything related to premises like infection control, fire safety, this is they're interested to look at. So at the same time, Secrecy will monitor you. Secrecy will monitor your performance to their monitoring. Whether you have any patient's comment, any TMC staff, or anything that really they need to come in quickly. So be careful about what kind of messages people putting on NHS choice, or what kind of complaint you are getting, because at the same time, Secrecy will monitor all the good outstanding practices. If anything fall apart through the net during the pandemic, that because people are busy somewhere else. Now, good and outstanding practices will have a visit every 5 years. So if you are in a good outstanding practice and you didn't have a visit for 5 years, you are going to get it. So that's probably happening June and July. Now, if anything happens in the practice like that, like a senior partner who of a registered manager has retired, or anybody passed away who was one of the registered manager, that practice will get a visit because we will have a new registered manager. If you have a merger with a big rig size more than £1,000, there is a most likely you'll going to get a visit. Okay, as I said, that you have a new building, or your practice manager just retired who was the registered manager, and new practice manager came, so you might get just a telephone consultation for that practice manager, that partner. You might not get a full visit, but you will get some kind of communication from the Secrecy. The next slide, please. Okay, now what exactly Secrecy is now more interested about is what exactly, I'm going to touch only one side today, because remember that everything I cannot cover today, and it's not appropriate to cover everything because not everybody going to get everything. So whenever you have a make a tail discussion with you, so we'll do one-to-one with every practices who is coming into the so when Secrecy are going to look for your online telephone access, video consultation, these are the things they're going to look at. And they expect to really put down in your clinical note that you have appropriate identification of right patient. So you are going to talk to, because remember, you are not really seeing a patient, you are just talking to them. You need to make sure that you have identified the patient, date of birth, and you recorded everything there. Okay. You also need to tell patients about that, what the video telephone consultation look like, and then you just need to ask that, is anybody surrounding the patients? because if the patient is talking in the office, or patient is talking in the house, so is there any children around? Is there any children with the accompanied parents? And are other people happy to speak in front of the patient you are talking to? So you must really ask the patient, is anybody in the room? Is there, if anybody is in the room, are you happy that person to listen what you're talking about? You might have to need to take the permission of that person, whether he's or she is happy to be on the consultation, because it could be your virtual chaperoning. So you must have to really record everything. So the secrecy will look for when they will access to your computer for 4 to 5 days, whether all your clinical medical record has those kind of dialogue, whether it's a rich coded, whether off text, they will find out somehow. So they will do a search on that. Okay, so make sure that you're ready for consultation to begin. You just tell the patient that I'm going to, whether you're going to give a phone call or your video, you want them within 5 minutes time, I'm going to send you a link. So you give them enough information so they can really maintain their privacy and dignity, and then you can respect people's own space. Now, okay, so so you make sure that you are, sometimes what's happened, we ring patient in the early morning and say, doctor, I'm just with my child, but I'm walking to talk. I just wanted to talk about my husband's methotrexate, because receptionist said, I cannot issue if I don't speak to you. So please make sure you stop this conversation at that time. You don't discuss anything when people are in a public place. Your patient might feel comfortable, but you shouldn't allow these things to happen, because it might come back from the bypasser that doctors breaching confidentiality, and this can cause the problem in the future. Right. So as I said, that you must allow them to have a private space. You tell them, okay, tell me if you cannot talk now, when can you talk? And you allocate another time for the patient to talk. Don't hurry, and don't take inappropriate consultation in the wrong time with the wrong people. Right. Okay. So, and the secret system, what system are you going to use? If they're correct, now I need to ask, I think Bhupinder is also on the line probably. I need to know that what sort of data agreement we have with Accurex, how everything is stored. So that needs to be discussed as well. Though we do have a valid system to medium to do all this consultation. Next slide, please. Okay. Now, safeguarding online. Okay. So what exactly Secrecy will do, that they will like to see, has the practice, has a system or assessing risks. The things we put down, I'm here, these are the headline of your policy of risk assessment. Has the practice conducted a risk assessment appropriately? That means what is a risk assessment? The risk assessment for the video consultation or telephone consultation regarding anything like safeguarding issues. Okay, so what they're looking to find, the potential risks that on the phone, video, and online. So whether the patient's in the right place and you have a good environment, you give patients enough confidentiality, and you have parents there, or if the parents are talking in behalf of the child, did you see the child physically on the video? So those need to be really recorded, and so the inspector or doctor can have a look. Okay, so you must usually speak to the patient that what is the effective safeguarding you are going to do for them, and how you're going to investigate, how you're going to implement that. You must do everything with agreement of patient. You might have a suspicious, you're not going to tell the patient, but you need to really arrange a follow-up if you don't want to disclose that you are worried about child safety. But you must have follow-up. You don't left the patient without knowing what exactly you are going to do. Okay. Also, when they receive the treatment video, you make sure that you are safeguarding all the treatment they're providing, all the referral they're doing. So you are doing in a way that it's not really handing over to somebody else, a third party, if you're using any kind of application through your mobile phone. So you need to make sure all the applications are registered through the CQC for the NHS purpose use. The next line, please. Right. Okay. So I'm just giving you an example about that, how we are going to show when we have a visit on 8 to 8 hour service. So I'm saying here, Newham Health Collaborative has system of identifying patient with safeguarding, and we flag and alert on their records. So you need to read code them. You also check the patient identity record and monitor on each contact. So you just make sure you are talking to the right people each time you are really accessing to any kind of conversation. On the clinical, non-clinical staff are trained. You need to tell that all our staff trained on safeguarding. Now, any registered practice manager, I just wanted to emphasize on that. We have an experience in the past. Any practice manager registered with CQC must have level 3. Must have level 3, even though she is non-clinical, but still she should. So any registered manager, whether clinical, non-clinical, must have level 3 safeguarding training. Following that, so then you need to check that what sort of safeguarding things you do in the meeting. So you need to, on your protocol, you have to say following that we take an appropriate steps in the practice meeting, and then take the all the action to protect the patient. And you need to really show them, demonstrate that what exactly you did. Okay, so then you need to check that in our protocol, particularly vulnerable patients may include that who has got previous history of self-harm, substance abuse, drug disorder. So what CQC will do, they will do a search, because remember, you don't have to provide any documents to us nowadays. What we have given, like I have a secured Microsoft laptop where all the search is built in. I cannot do anything. I have given a smart card, and I have given a login details for any practice in UK who I'm going to take the data from. With the practice permission, I will do this pre-built search from my house, and I will collect all the data. So you must remember that all these search are built in. So you are not going to provide any data. So who is going to look at what criteria, that will be given when you got the letter. So as soon as you got the letter, you must contact us, because we know what searches they're going to look for, and we know how they're going to find us. So it will be very appropriate when you have received a notification from CQC, you speak to us directly. Next slide, please. Right. Okay. Now, okay. So what exactly happened? For example, you have a health professional, you gave a laptop. During the first pandemic, we've been overexcited that everybody got a laptop working from home. So you need to make sure whoever giving you a laptop, you have done 4 steps. Step 1, you need to make sure the responsibility to protect dignity, confidentiality, suspected abuse. So what exactly you need to do? You need to do an induction on that, and you need to demonstrate which day when you did the induction, you included all this item I'm talking about. You spoke about patient protect the dignity, confidentiality, response to suspected abuse, safety concerns, smart card policy, working from home policy, protection of overhearing at home. I think we have something in NHC. If you don't have a copy, you can contact Asma Karim. She's a wonderful policy from working from home. And as an NHC, we are happy to support you all the way. As we say, we have a bunch of people already support you a lot, and you can reassure that we will not left you to suffer. We will suffer with you. Okay. Now, then you need to do the personal and collective responsibility of individual patient raised concern and other colleague. You need to show that you are speaking to in a practice meeting. You speak to your other health professional colleague. There has to be some kind of in the notes need to have that I can, when I dial in to any of your consultation, that you have coded as safeguarding, consider you have spoken to the pediatrician, you have spoken to your partner, you have spoken to the staff, you raised a concern, you alert them, you ventilate their concern. So there's some kind of things that I need to see remote dialing, that you have got those information there. Either it's an off text, whether it's read coded, it doesn't matter. Somehow we need to see those kind of evidence. Okay, so now we need to see that each consultation has contained quality and safety, whether it's telephone, whether it's face to, whether it's video, it doesn't matter. Because remember, we have now a tools to go to your system to find out how much telephone consultation you did, how much face-to-face consultation you did, how much video consultation we did, how much e-consultation you did. So we can get all this information, and we can randomly select 5 of them to find out, does it contain the quality of consultation and safety of the consultation. If you wanted to know what that means, I can run another workshop later on. So I will really ask Nadim and Karen if we can have a 20 minutes every month to discuss about new things that are coming up, so we can prepare the practices to face any future. Remember, CQC is the media I use to raise the quality. It's not to raise the fearness with the people. I think this is the most effective way we can raise the standard of general practice. I know it's sometimes overburdened, but if we all work together, we can really share each other's stress. Okay, so the next step that you must set up an effective treatment to identify and manage the risk. Your risk management. If anybody doesn't have the risk management tools, please ask us. We can provide you one risk management tool. It's all over the places. It's available, Google, or I can give it from what we have from the CQC. Okay, and you need to really identify risks very quickly if there is risk of harm. I need to show some of the evidence that you work very quickly, because remember, we are very worried what happened to the pandemic about the predator was waiting for this chance, because people cannot mourn, people cannot go, they cannot contact their family members, they are isolated. So there is a lot of domestic violence happens. We know that these are unreported. Now things are cooled down. We need to go through those kind of things, whether we can dig out anything and make patient life safe. Next slide, please. Next, okay. So what exactly we are looking for here? That you need to ask the patient, as I said, who is in the room. Is that patient happy to their partners to be in the room, or is that partners is happy to be in the room? So you need to really document everything. The patient give me a warmer permission to do a consultation alongside with the partner. So you need to demonstrate those things. Okay. So you must have to elaborate everything patient say in details, because you are not seeing the patient directly. So if anything that patient say, you must ask the question unless you satisfied, you understand, and patient has got chance to say what they wanted to say. So you need to make sure that you have all this information in your consultation. I know it's dangerous because each consultation probably 1 hour, but remember, your 5 consultation will determine your quality of consultation. So this is where the challenge lying down, because we randomly check your 5 consultation, and from there you can see the quality safety is there. So you need to make sure that you record something. If it's a consultation with the child, I think speak to the child, because the child should not be a passive agent on the consultation. You try to speak to the child. Why you're speaking to the child? To see the child's mood, is the child depressed, is the child happily engaged, is the child able to comprehend, if there's a kind of fear, the child is low mood, anger, any physical sign, any cuts on the face, this is all needs to be documented.
Yeah.
These are all we are going to look for. Okay. So if there is a possible to see the child in the video, you must see the child. As I said, that you must mention the child was comfortable at rest, child had good eye contact, child is, whether there is a fearfulness, if the child look ill. So what sort of things you get on the vision, you have to document those things. You just cannot just say video consultation, patient looks well, is fine. No, it's not. You need to give some kind of, you need to justify your judgment, how you feel the child was safe and this child was at not risk. So you need to document something. So when I go to your system, I can find those kind of clues. After consultation record, you carefully write the notes. So you can do, look, safeguarding is not we see 10 a day. We probably see 1 is in a month. Spend time on that, because that will determine your practice profile. So make sure all these high vulnerable practice you document properly, because we are not seeing every consultation. We are only seeing this is 5 vulnerable group, mental health, learning disability, dementia, all these patients. Next slide, please. So you need to make sure that
Yeah, sorry, Sabir, we're just running a bit late now. I know there's a lot
fine.
of there's
Look,
quite a few more slides
I
left.
think I will leave the video consultation to people. Only things I will say that you must remember the GM60 principle. Okay, so I will send all the slides to you. You all can all the slides. As I said, I'm the part of the pilot. So if you need any help, please let us know. I'm happy to do one-to-one as I did all the time. So we can do the team net. With that note, I will finish now, and nothing to fear. We are here to help you because we know the trick now. Thank you.
That's fine. Yeah, thanks, Sabir. As Sabir said, in NHC, if you need any help, then contact either Asma or Sabir, and we'll be able to do that. And I think, like you said, it might be a good idea to have a bit more teaching in detail about CQC. I'm not sure if the webinar is the right place to do it, though, only because it does need a lot more time than we have in this meeting, Sabir. But thank you. There's a question from Bapu. Do they check consultations of locum staff? I mean, I assume they do, Sabir.
Everybody's consultation. Look, we are going to dial in and we are randomly checking because, as I said, that our computer is built in with those kind of read codes, okay? And those read vulnerable, mental health, patient at risk, safeguarding raised, physical violence, domestic violence, anything in the computer, it will pick up. And
that's
then
fine.
we'll go to this particular consultation to see whether it's a locum, whether it's a partner, whether it's a practice manager. We'll dig into it.
Okay, thank you. Wax, you've got your hand up, so quick question, please.
Yeah, so Sabir, thanks as ever, and I look forward to the snap sessions that you do. Nadeem, mine's a bit of a strategic question. As a practice, I'm a little bit stunned, getting a bit of vertigo. When I turn to the left, I have equip. When I turn to the right, I have CQC. When I look in the middle, I have QOF. I know which my priority is. That's QOF and CQC. There's only so much QI we can do. I just wanted to understand, and it might not be for the answer for today, but I think we need to get an understanding that the resource that's going into all the QI that we are doing, is it being channeled in the right way to deliver on that QI that we need to do in QOF and for CQC, because we are very, very busy and there isn't much time for fancy. I would love to get on and do fancy, but you know, I think practices really, really would welcome the support with the amount of QI that there is in QOF and other things, and the CQC, when it looks like it's going to be a very rough CQC situation. So, you know, things like a practice given a little bit of time to do some CQC, etc., 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 because that's the only way that we could add the support that you mentioned.
Good point. I'm not sure we've got anyone here who can answer that, but maybe the next person on the agenda may be able to.
Maybe for the transformation group as well.
Sure. Got Anthony, you've got your hand up. I think we'll have to move on after this question, though. Do you want to go?
Yeah, hi, it's Manuel from Custom House. We had our CQC visit like 30th of November last year, and this is especially on the utilization of appointment slots. And the CQC inspector said this is nothing to do with CQC inspection, but NHS England have asked us to do this. And so the specialist GP inspector, he actually was looking randomly on a specific day of all the GPs, clinicians who were there, looking at the appointment type of slots, and went into the consultation to make sure that it was actually a telephone consultation with the patient and not some other work like admin, clinical admin work. So is a new inspection, are they going to be looking at things like that?
That's right. Can I just answer it? Look, there is a joint committee on quality. This consists of GMC, CCG, NHS England, CQC, and RCGP. So now a joint statement came. They're all looking for the same thing. So now you will not have a different visits from different people. So they're all together, and it is called quality joint statement. I can send it to all the practices to have a look. They all agreed to have one visit whenever it's, and it is a requirement for these 4 parties.
Sure. Okay. Thank you for that. Karen, maybe if we could just have a think about where we're going to bring the CQC item back. We do need some local import, and I know there's been a couple of CQC inspections already, and they are starting again. But thank you very much, Sabir, for that. Next item is we've got hi William Cunningham Davies, who's joined us as the incoming director of primary care for TNW. Is that correct, William?
Yeah, hello there, and hello everybody. Sorry for being a few minutes late, and
That's
apologies
fine.
I won't be able to stay for the whole period, but a very, very useful presentation from your colleague, and like you're saying, very, very in depth, and I'd suggest probably a kind of a much more dedicated session on that. So again, I've learned a lot, so thank you. So yes, so I'm William Cunningham. I'm the new director of primary care transformation for TNW. Obviously, there's the old well system you'll all be aware of. So I started 3 weeks ago, or coming up 4 weeks now. So just kind of getting out there, meeting people, saying hello, just understanding the geography. So a little bit about me, if that's helpful, Chair.
Yes, go ahead,
Yep.
William.
So I've been in primary care or in GP land for over 18 to 20 years. Again, very much moved around from North London, so Northwest London, and then down to South London, and then into NHS England for the region. Did some work in the national team and for the region, and then back to Southwest London. And then obviously we've been fortunate enough to come and work in the TNW patch. So again, for me, is very much we're looking forward to working with you all in a constructive and productive way from point of view of getting primary care very much on the map, very much looking at a kind of local flavour and how we make sure that we are able to champion that. And again, obviously for me, I know Karen, we've talked and met, and I know Nadeem, we've spoken as well. But it's just really kind of me just getting my feet under the table and kind of finding kind of the layout of the landscape, and really understanding what the issues are that you face at general practice, but also the system faces, and see how I can and the team can support to unlock those areas. Not a magician, but again, it's very much about how do I support, and obviously just kind of it's for the long game, but what can we do in the short term to get some quick wins as well. So hello, I don't know, Karen, I know you put like I was going to be down for a Q&A. I'm not going to be sure I'm going to be able to answer the questions because I'm just newly in, but again, if there are questions, thank you for Charlie. So yes, it's really just yeah, if there's any knotty issues you might want me to take away, apologies, I've got a call at 1:15, but again, very much happy to be contacted.
Thanks, William, for that. Yeah, we're looking forward to working with you as well. I mean, this is the monthly NHC webinar. We have 2 a month, one here and one is CCG led, and it helps us to engage with our practices. So if there are any questions for William, but I'm sure you'll be coming around and meeting not just the federation but the practices and the clinical directors in due.
I see Wax has got a question, Nadeem.
Is that a legacy hand, Wax, or is it?
No, never legacy. So the question that William, that tends to come up in various forums that we have, sort of primary care forums, is around decision making and where that where that happens in primary care, and where that happens for primary care. And did you want to say a few words on that, just to let some of the colleagues be aware of where we are at the moment with that kind of situation?
Yeah, so I mean, you'll know more than I, Wax, but also do chip in because obviously we've spoken about this and around what the structure looks like. Yeah. But so just to let everybody know, so obviously from point of view of the NEL system, we now, so obviously from NHS England, obviously the core NHS contracts are delegated down to the TNW or to the NEL level, and there used to be a well primary care committee, so any sort of contractual changes, so boundary changes, 24-hour retirement, partners coming on and off, any kind of breach notes, obviously we just talked about CQC, for example, they would have to be ratified in public with a group, a cohort or committee that kind of underwrites the delegation agreement from NHS England. That now is a kind of coming together of one CCG for all 7 boroughs or the old CCGs. There's now one decision-making process for all of the delegation elements that sits at a NEL level, which is again chaired by a lay chair. So obviously, you know, one of the issues, I'm sure one of the questions is very much about the equalisation and kind of the SNSs, or LISs as I call them, the enhanced service floor, around how do we work through that, review and make sure they're fit for purpose, but also meeting the local needs as well. So again, that's a big piece of work that needs to be done. Again, there's very much a helicopter view at a NEL level, but very much trying to look at where the decision making is being made currently, where should it be, and who by, and kind of how the partners are engaging in that. I've got my own personal view. Again, I'm looking at having various conversations with various people around where it should sit, but ultimately is around, you know, kind of making sure that we get the local flavour right in the borough, but making sure those decisions are also kind of signed off on the correct governance route. And I know, like I said, Wax, with your primary care SRO role for TNW, obviously we're working with yourself to crystallise that and be able to share that with the member practices.
Yeah, I think we just where we want to be is, you know, there's clearly transformation that needs to happen. We want to be in a space where we can do that with some agility.
Yeah.
And I think, you know, going constantly up to NEL, etc. You know, it's just we're just not going to move things along. So, you know, it could be X in a practice or X in a PCN, etc., where we can quite happily do things at where they're appropriate at a local level, but actually at that slightly wider footprint at that TNW level, where, you know, that the quality improvement, for example, that conversation, or you know, phlebotomy when it comes to working with BARTs on our footprint, where that primary secondary care interface meets. So we know over the weekend in the media that primary secondary care interface is going to have to change for things to move along. So you know, constantly having to go up to NEL, you know, it's just not going to give us that kind of flex and pace that we need if we talk real transformation. So I think, you know, with everybody on the call here, and as we have our practice councils and stuff, and we have our local GP transformation subgroup, which is an excellent forum where we all come together, PCN, CDs, Federation, LMC, hopefully some of the reins can be handed over here, and we can make those transformation decisions at some pace, rather than, you know, this month has to go to that group, to that group, to that group. Of course, where the governance is needed for some of those decisions, yeah, it will have to be now, you know, APMS and XY, you know, some of those kind of situations. But yeah, so that's the conversation, and I think we've got a clear idea, but you know, we'll always be welcoming steer from the practices as to you know, how we can improve that, how we can develop that, and just so we can get into the right space to get the transformation we need.
Okay, thanks, Wax. As you mentioned, Wax, equalisation across TNW, which is something which is historical and quite important to us in Newham, SNSs and decision making. And I suppose the other thing is in terms of your views on the role of feds in TNW and across NEL. I'm sure you can't answer the questions now, but they're just some of the kind of themes that we've got locally. Absolutely.
You know, I mean, there's an absolute role for the Federation. I mean, it's the overarch that has supported the practices through the pandemic. It's been very, very difficult. You know, if we didn't have Federation, if we didn't have situations that we had, boy, it would have been extremely different. And then with COVAX as well, delivering 100,000 vaccines as of last weekend over that period of time, that's no a small feat whatsoever. So, you know, all of this is in that conversation. Where PCNs work, where practices work, where federations work, that's where we want to get to. And we need to make sure the resource is funneled in a way that it's really hitting those points where transformation is needed.
Thanks, Wax. So the questions were for William. Is there any comments you want to make, William? Or
so yeah, so I think very much the equalisation is very much about, you know, and the kind of roles. I think Federation, again, as Wax, and my internet apology froze, so I missed some of the conversation. So, but ultimately is for me is around, you know, at scale and actually supporting general practice. And again, is from where I came from, was very much around the Federation and practices working a lot more collegiately and close together to kind of run the COVID kind of campaign, etc. But as NHS England kind of turns on the services and trying to get practices back to BAU, I think actually how do we have that kind of viewpoint of, you know, what could be done with support from the Federation at scale, and actually allows you then to, as a practice, to kind of focus on those certain areas. But I think for me, like I said, is very much about, you know, Federation, PCN, and obviously then practice. It's kind of washing it all together of what are the advantages of doing stuff at scale, both as just as even as workforce, let alone how that kind of plays out. So again, it'd be interesting conversations we'll need to have with yourselves, and also around with practices. So actually for me would be one of the conversations I'd be looking to have with your federation of how are you as a federation going to be able to offer services to practices for them to engage and to buy into from yourselves. So hopefully, again, as you said, the good work that you've done around the COVID vaccination support, actually that hopefully should stand you in very good stead of member practices saying, yep, I'll happily get you to carry on doing that, which will allow you then to flourish in that respect.
Okay. Thank you, William. Like I said, we look forward to working with you locally and having you back on the webinar. Thanks for coming today and taking the time out.
Apologies, I'm going to drop off. Thanks very much.
Thanks. Can we get the agenda up, please, again, Karen? Has it disappeared off my screen? So I think the next one is Beth, who's going to give us an update on the vaccination programme. Hi, Beth.
Hello, sorry. Yeah, so I don't know, Maggie's got some slides, probably easier, Maggie, if you can put them on the slideshow, just because there's some pictures in there. But yeah, just to, as Wax said, it's been incredibly busy last couple of days, and we'll probably get even busier. I thought it would be good to just kind of have a look at where we're up to in terms of what we've achieved. So can I have the next slide, Maggie, please? Yeah. So as I think it was Wax was alluding to, this week LVF Sites Combined in Newham, so the two sites, SLG and Essex Lodge, have delivered over 100,000 vaccine doses. SLG about 3/4 of those, and Essex Lodge about 1/4. And the SLG site has now delivered about 11% of the total LVF doses across now, and 6% of LVF doses and 6% of all of the doses given in now. So I think hats off to the team here, quite frankly. Yesterday, I think we all felt it somewhat. The current record now stands at about 1,300 doses in a day, and boy, did we feel it yesterday. So next slide, please, Maggie. So with that, looking at, and the difficulty is always we have a number of different sources of data. So you'll see a number of different sources of data here, but the NEL dashboard tells us about 124,000 people in Newham have had a first dose. The cohorts 1 to 9 now, the total number we need to vaccinate is now very, very close to 30,000, which is significantly lower than it was when we added in cohort 9. And all the cohorts 1 to 6 are now under 10,000, with cohort 6 being the biggest, and that's just a squeak under 10,000. So that really sort of starts to make the numbers look a little bit more manageable, at least. I say a little bit. I'll come on to the what's next shortly. And the other thing, again, Wax alluded to it at the top of the meeting, there is a lot of vaccine coming in to both sites, actually, and it's all Pfizer for first doses. We have had over 2,000 doses, so 2 pizza boxes for the next, for as long as I've got delivery notifications, which is the next 2 weeks, and possibly a bit more. And I think because we've been so enthusiastic to use up vaccine, we're also on national speed dial for any vaccine that's going spare. So, for example, yesterday Cable Street in Tower Hamlets decided they didn't want their Pfizer. We took it in SLD. So we are working our way through that now, and we've always been able to find a way to absorb additional vaccine for our local population, I think within reason. But anyway, it's worth knowing that that the national head of vaccine logistics rings me when she's got their vaccine. These are some pictures of the numbers needed to vaccinate. So for the uninitiated, numbers needed to vaccinate is the number in the cohort less the number who've been vaccinated already, less the declines and the contraindicated. So you can see, so the bottom line is cohorts 1 to 6, steadily going down, but has flatlined for quite some considerable time. And of course, the top line, it sort of goes up and up as we add in new cohorts each time. Next one, please, Maggie. This is the numbers needed to vaccinate in each of the individual cohorts 1 to 6. Again, you can see cohort 6 at the top there, and it sort of dwarfs all of the rest of the cohorts. But again, you can see that whilst there was initially in all of these cohorts a nice big decline, we are in the territory of marginal gains, but small gains every week. Next one, please. And this is dose 2. So again, you can see dose 2 continuing to come down, but of course so the bottom line is cohorts 1 to 6 again, and the top line is, of course, as we add in new cohorts, you get a big jump. And next slide, please, Maggie. I think that's all the pictures. Yeah. So aside from the raw numbers, I think it's worth just reflecting on the fact that the Federation have been able to establish the largest and most productive LVS in North East London on behalf of Newham practices, and something that I think Newham should be incredibly proud of. And that we have those 2 LVF sites who've now delivered between them over 100,000 doses. We've also been able to work with the Newham Training Hub to establish a process for getting both registered and unregistered staff trained. And to date, we've had 29 registered professionals to vaccinate through that route, and 49 unregistered. And a lot of those unregistered staff are medical students who have now completed the process and are helping to fill the rota. We've established a process for centralised uploading practice cohort lists. So the reason why we were able to fill so many appointments so quickly yesterday and the day before was because we uploaded your 35 and overs. And now, because of the multi-generational household pilot, we have it kind of established the wherewithal to really free up all of the cohorts and just throw the doors open and vaccinate people now. That's not to say, please don't send me a whole load of walk-ins this afternoon because I've just thrown the doors open. We're still working to book appointments. Not quite there yet, Maggie. We should have rehearsed this. We've worked with LBN, and now there are a large number of call centre staff who are calling and booking people in using the AccuRx or AccuBook system. They have been trained to book appointments. They are mostly prioritising the second doses to make sure that we get those in. And then finally, that's part of the reason why we're getting so much of the Pfizer through the doors now is because we are now a designated Pfizer centre for the borough. So what that means is that we can vaccinate people like the NUH staff where the hospital have closed their doors. Their vaccination centre has finished, but their staff still need second doses. Now I need the next slide, please. Thank you. Okay, so that's all the good stuff, right? Here's the bad stuff. So aside from the fact that I've got a lot more grey hair than I had back in December, there's still about 335,000 people at least to jab. We have just, in fact, it's actually the numbers that came this morning, it's 38% cover in the adult population. So it creeps up with every dashboard that arrives. but it's a long way off herd immunity. And you heard Wax talk about the India variant and other things at the top, again at the top of the meeting. So there is more to do. And of course, there's all the second doses, and then actually, well, we have boosters to do as well in October. The summer, of course, means lots of travel and lots of socialising. So we want to make sure that our Newham residents are as well covered as they possibly can be for all of that. And the vaccine supply for all first doses is, of course, Pfizer now, and for the foreseeable. What we do have confirmed second dose supplies of AstraZeneca, but it makes the dispersal model quite difficult for first doses now. Well, nigh on impossible. I believe that there is some work going on to look at how Pfizer can be used in some of the pop-up sites, but I think even when that gets the go-ahead, it will be probably quite restricted. So it makes some of that delivery a little bit more challenging. And the next slide, please. So I think in summary, then I think there are 3 challenges for Newham practices and the Federation and LBN and other providers like the Red Cross to meet together. There are, as I have just hopefully illustrated, some very large numbers still to vaccinate to achieve anything close to herd immunity, and that's an important thing that we do for population in Newham. Large numbers of people potentially incorrectly coded. Have we got the baseline right? And if we haven't got the baseline right, then actually let's make sure we get the baseline right, because then we know what we're chasing after, and we can actually monitor the progress that we're making in real terms. And like I said, our first doses, for the foreseeable at least, have to be delivered through those LVF sites, and hopefully Westfield 1 and 2, as they are now fondly known, will be delivering Pfizer. But my understanding is for Westfield 2, that's not going to be until mid to late June. So yeah, I think that probably covers it.
Thanks for that, Beth. And as you said, 100,000, over 100,000 now just from Essex Loss and SLG. I think most of what's been done locally is via primary care or LVF sites. And like you said, we've got over 300,000 to do locally, and we've got the extra challenge of the Indian variant, and I suppose hesitancy as well as you get to the younger population, although we are making inroads into that, it seems. I was just going to ask a couple of questions, actually. In terms of the pharmacies, are they not able to do Pfizer at all?
No.
No.
No space.
No space.
So I think some of them are, but it's the bigger ones, and I'm not quite sure. I don't think we've got one on the patch that's doing Pfizer.
And
no, not even Boots Spectrum.
Okay, well, any Moderna locally coming at all? That was a
I
question.
don't think there's. I could be wrong, but I don't think there's any Moderna at all in North East London. I think there's still only one site in London that's doing it.
Just the Islington Design Centre is the only place.
Okay, Wax, you got your hand up again.
Yeah, so Beth, on that 37%, I think it dipped up to 38% in terms of uptake overall across all the cohorts. If I give you an example, in Havering, they're up to 60% of that uptake. Now, bearing in mind the Havering demographic is completely reversed to ours, I'm kind of hoping as we go to the younger cohorts, those percentages try to, automatically equalise, if you see what I mean. But it still does show that we are well away from that herd kind of situation, although the general level of antibodies in the community unrelated to vaccine are still quite high. And then the other thing, Beth, was on the getting the baseline right. Look, I'm telling you now, I've got patients on my list that shouldn't be on my list. We've got no contact with them. They've got breast screening overdue, smear screening overdue. It's absolutely shocking, ridiculous. We need some kind of template or some way of sorting this out. And that does involve taking patients off your register. But, as Jenny said at our last meeting, there's no reason for those people to be on our register. So I'm just wondering, have we got a template that we can give to practices, or CCG could come in and support practices to tidy that up? Because I think we're chasing a load of ghosts. And then the other thing, just on the 100,000, and really well done to SLG and Essex Lodge. There have been lots of practices that have, in those figures that Beth has presented, those practices that have been doing their housebounds or doing pop-up clinics and stuff, really well done, because all your vaccines are in that count as well. So it's been a cross Newham effort. We're kind of a third of the way there. We've got a lot more to do. Beth, before I go, I just wondered whether you could say something about the call recall kind of situation, and also about the KEG dashboards, because I still haven't seen the KEG dashboard or been uploaded, or a new version been uploaded to our EMISs to allow us to help the system along with getting some of those patients called in, or texting them out, with the support of some iPlato text from CCG to get them to have the vaccine.
I think colleagues from KEG are actually on the call today to talk about that, so I won't go into
Brilliant.
that.
Excellent. Thanks, Beth.
I don't know if Nadeem knows he's on mute, but I think that's it. Go.
Hiya, Beth. Just to say, Wax, the question you're asking can be answered by our next presentation, which is Bhupinder and some of our KEG colleagues.
And then just Nadeem, on the call recall, Beth, do you want to just tell us what the LBN offer is around the call recall, and what practices should be doing or what not doing, if you see what I mean?
I don't think there's anything specific from practices other than to note the LBN website, which I will stick again in the
Thanks, Beth.
in the chat now, the Book Your Vaccine website, so that you also are able to just let patients know that's how to call or who to call to get booked in.
Brilliant, thanks, Beth.
And that QRX message might be worthwhile across Newham as well. Wax, if you can just take that forward. Thanks, Beth, for that. Could you stay till the end of the meeting as well, Beth? Would that be all right? Thanks. Bhupinder, you're next with our KEG colleagues to talk about searches, and is that okay, Bhupinder?
Yep, I'll try my best.
Guys,
The KEG colleagues are probably.
Can we mute
hear
if
me?
we're not speaking, please, as well? There's a lot of background.
Can you hear me all right?
We can.
Great. Oh, well, I'll try my best. Who's here from KEG? Would be helpful.
I'm here. Bhupinder, Joe, Dissier, and Keith's here too.
I'm here as well. You know this much better than I do. I'll do my amateur version. Do you want to share your screen, or shall I do my EMIS screen? Is that okay, Joe, for me to share it and show the searches you've done, or did you want to do it?
I mean, I'm happy to do it. I'm happy to share my screen, and I'll give it a go and see. And if I get any problems, then maybe I'll give it back to you, Bhupinder. But I can share my screen now for EMIS.
Okay, whatever you want to do. Yep.
Okay, let me give it.
I've got my screen ready to go.
Okay. Is that working?
Yeah, we can see it.
Okay. Do you want me to talk through them, Bhupinder, and then you make any comments?
Okay, that's fine.
Would that be helpful? Okay, so I'm here really just to describe the CG products that we've designed to help you with the COVID vaccination recall program. So we've produced a number of searches that you'll find in your population reporting folder for all the practices, and they're right at the top if you look at this clinical effectiveness group. And these searches, I'm guessing that you're probably familiar with them because we've been building them, since the beginning of the program, but they're in the folder called the COVID-19 CEG support, and they're in the first folder there called the COVID Vac recall. And they've got the age from to identify the cohorts that they're looking at, actually. Now, they look slightly different. You'll see that they're different from searches that we built at the very beginning. And we've changed the way they're built, primarily because the searches were, in fact, becoming quite unwieldy with all the different groups. So I'm going to explain them just to make sure that everybody is familiar and kind of understands how they're working. So if we look on this side, what you're looking at is you've got patients who are aged 16 plus. They're not coded as being in a care home, and they're not coded as being housebound. And then from that group, what we've got here is the next search, which is patients who need to get their first dose. So these are patients who have obviously not been vaccinated, they've not got contraindication, allergy, or declined coded, and they have actually also not got coded that they've been invited for a vaccination. And then from that amount of patients, we now then look at patients who are in the high or moderate risk groups from COVID, or they're aged 40 plus. So what's that? That's cohort 10, isn't it? I think cohort 10. So, and it's split. We've split it into two groups here. One are patients who can receive any vaccine, so they can receive the AstraZeneca or the Pfizer, and then you've got your list that you can upload to AccuBook. And then the next group down here are the patients who can only receive Pfizer. Well, as you said, I don't think there is Moderna out there yet, but who can only receive the Pfizer. So they would be your patients who are coded as pregnant, or the under 30-year-olds, or we have also picked up people who are at risk of blood clots. That's your first lot. And then the second lot, so B, these are people who have been, there's been an invite coded, so you've invited them in, but there's not been any outcome. So they haven't yet been vaccinated, declined, contraindicated, or declined. And then again, split into the same groups as above. So they're either at high or moderate risk, age 40 plus, they can receive any, or they need to get the Pfizer. I don't know whether in Newham how it works with calling in the second dose, because I kind of work with City and Hackney, so it's slightly different. But anyway, there's a suite of searches here that will identify patients who are ready for their second dose. Again, split into those who've not been contacted yet. And then the next one, similar to the above, are the ones who have been invited, but there's no outcome. So those are the suite of searches that we've got. Did you? I wanted to show you the invite template as well, but Bhupin, did you want to mention anything about the searches, or if there's any comments?
No, I just wanted to say the old searches, which people are familiar with, are sitting in X at the bottom. If you could just click that.
Yes,
because that's what everybody's familiar. So they are sitting there, the cohorts 1 to 9. So that's what you're using. Every week you have to keep changing them, and I've just realized that even the search I've got is probably old, because I've got the +50 and now it's gone down to +40. So if you don't update your searches pretty much every week, there's a danger that you're out of date. That's all.
Okay. I want to just show you just this other folder as well, just so that you're aware of this. This folder just splits your patients, your SMI patients and your learning disabilities patients, just as two kind of separate cohorts, just to see how you're doing with the vaccination of those two specific groups. So you can have a look to see how you're doing there. Now, another product that we did for practices was around coding the invites. So we built a template called the COVAC invite follow-up template, and I'm just going to quickly show you this. So this template was to record when you are when you're contacting patients, you know, either if you're sending them letters or you're actually telephoning them landline, really, because the other stuff will go via AccuBook. So this template you can use. It'll show you, the first little bit shows actually if they have had any vaccination. It'll just give you the last coded entry. You can also just code in this little section if a vaccination has already had if the patient, sorry, has already had a vaccination. It's not being coded because they had it abroad, and you want to actually code that they've had it with the approximate date and brand in the free text box. Then if you come down here, there's the opportunity to code, yes, I'm contacting this patient, I'm inviting them in for their vaccination. And then we've got a little text box here where you can put mode of contact. So if you were doing it via landline, you might want to put landline, you might want to put letter. And the reason for having this extra text box is because, remember, there's only one vaccine invitation code, and that one vaccine invitation code actually says SMS text message sent. So in order to have good data quality in your record, it's important to put the sort of mode of contact as well, just for your own records. If you failed encounter, then you can record there that there was a failed encounter. Then what we did practices were asking about, well, what happens about those patients who are deferring the vaccination? And unfortunately, there wasn't a SARS-CoV vaccination deferred code. So if you're phoning somebody up and they say, actually, I don't want it now, but I will have it maybe in, in a month's time, you can code here. SARS-CoV vaccination, first dose declined, reason for deferral. I don't know, I want to talk to my family a bit further about it. But then you can also code and treatment delay. This means that we'll know that these patients were deferrers, and you would be able to see that on a search. I'm going to show you the search where that shows up. Same if they've had the first, but they don't want the second vaccination, or they want to defer the second vaccination. You'd click that and treatment delay. Third section is that if you've contacted somebody 3 times, so you've done the 3 invitations, and they're saying that good practice, 1 attempt does need to be done by the phone, you can then code as declined. And again, that, if you click that, the text next to it will show unsuccessful encounter following 3 attempts. So again, for your data quality, you've got that quite clear in the record. If you phone somebody up and they say, well, we definitely don't want it, we never want it, I'm going to decline the first, or I'm going to decline the second, kind of true decliner for whatever reasons, I either had an allergy or maybe contraindicated, or for whatever reasons, you can put that in there. And then to go back, I'm going to just go back to the searches to show you the other product that we've done for you. So in folder 3, this will give you all the patients who have declined the COVID vaccination. This is a report so that when you run it on your own local practice site, this report, you can run this, and this will then give you all the details. I was going to show you, but actually it's quite tricky unless you can see all the patient names, but it'll give you the patient names, and then it'll give you all the details of those decliners and those deferrers. So you'll be able to see very quickly which ones are your deferrers. And that really, sorry, maybe just I'll mention this one other search as I'm here. This is indicates who are coded as housebound. And it might be that you want to have a quick look at the numbers that are coming up in here and see the patients and say, some of those actually aren't housebound, so we need to code them as no longer housebound. So in fact, they will appear in your recall searches. Otherwise, we have excluded the housebound from your recall searches. So that's just something to keep in mind. And I think that's all I wanted to say, actually. So I might just leave it open.
Thanks. Karen, any questions at all in the chat bar?
Just a keenness to have the presentation slides. I think because it's a live presentation, that will be tricky, but I'll perhaps, Joe, if you and I can link up if there's anything we can share out with practices.
What we have done actually, just with that little COVAC invite template, is I've made a little video on how to use it and where it is. So, you know, we can do that as well.
Lena, you got your hand up?
Thanks, Nadeem. I just have a question. I work quite closely with LBN on trying to understand where we are with supported living and who's had what vaccination. And whereas I can get some information on people that are linked to the SLG vaccine site and its subsidiaries, it's very difficult to, well, so my question is there a central place where we can find out whether people have been vaccinated elsewhere, whether that's in Excel or in other boroughs or wherever else, without necessarily troubling every individual's GP practice to look at their own localized EMAs?
I might have to throw that one out, Bhupendra. I'm not sure about that.
Vaccination site is recorded in the GP record. I mean, there might be notes, but there's no code for vaccination sites. That question came up very early on in the campaign, and there's nothing we could do at our end. I don't know if the national system Foundry might be able to, but very few of us have got access to that.
And there isn't really a good code for supported living. So I've been trying to find one. And so even if you do know, so if you did your EMIS enterprise searches on EMIS on those patients, you'd get, but it's the quality of data.
So I mean, I know the individuals, I know the EMIS numbers. I just want to know their vaccination status, I think is what I'm getting at. So so
then if you know their NHS number, and you can just use Pinnacle to find out what status. That's the easiest way of checking it.
I think the same thing. This is Dr. Dion from Customer House. The same thing on this note applies to patients who have not vaccinated abroad. When they come to the UK or when they come back to the UK, there's no code for us to enter that into emails. Is there anything anyone knows about this place?
That was in the template that Joe showed. So in the Kovac template she showed, and it's not easy to find because I misspelled it as Kovac, C-O-X. It's actually C-O-V. So if you actually look for it in there, there's a button there to press vaccinated abroad and the date that they had it done.
Thank you.
Hi, it's Manuel from Custom House. We also we have come across some patients who have been vaccinated but not been notified. So I was told that it's a national problem, and has that been resolved?
There are delays with Pinnacle stuff coming over into EMIS, and EMIS has acknowledged on many occasions that they've had delays in receiving it. So that's part of the problem, and partly it's where data hasn't been entered in time in Pinnacle, or it's human error. So somebody may have forgotten to enter 1 or 2 home visits they did, and the patient says, "Well, I had it done. Here's my bit of paper," but it's not. If it's not in Pinnacle, then it won't go into EMIS. So Pinnacle is the first port of call, then it goes into EMIS, and errors can be made at any stage. It's just that kind of process. So it shouldn't be very often, but delays have occurred from Pinnacle to EMIS of up to a week, is what I've been told. Is that correct? Anything else on that, Joe? Have you heard that before?
I haven't heard any more. No. Sorry, I'm just.
Yeah. Any other questions, Karen, on the chat bar?
I've got a question. Is what invites do you want us to send now? Because you're able to now send invites automatically. You're able to upload into AccuBook centrally. So what invites do practices need to do other than, I mean, that's a grey area for me now. So that would be good to get clarified.
Yeah, so I'm happy to pick that up with you. So centrally, we are sending out through the AccuBook system invites as the age cohorts move down. I think the thing is, what we've also recognised though is when patients get a slightly anonymous AccuBook text, they don't necessarily have the same relationship that they have with general practitioners. So it's an additional element, but I believe the CCG have been supportive of using additional iPlato if you used up your iPlato quantities, so that it's a more personalized message. People perhaps have a more comfortable relationship, that they connect in terms of trust from practices. So we will upload, we will message them through AccuBook, but we do recognise that some people don't respond as favourably as when they get it from their own practice.
Yeah, so I agree, Karen. So in terms of just complementing the work we're doing with the call and the recall, it's if there are patients who are hesitant or who request a discussion with a GP or primary care, so that's where practices can help us. So it's just to complement and supplement what we're does that answer that, Bhupinder?
Yes, that was very helpful. So practices do not have to upload into AccuBook anymore. That's being done centrally, and we can just support you by doing a second text. Okay.
Okay.
And then a little second question is, those practices that have been doing AZ to cohorts 1 to 9, if the AZ is no longer available, I presume that means practice-based vaccinations will stop. Is that correct? Until their supply is renewed.
So
unless there's a change in the kind of Moderna or Pfizer spec, which allows practices to do it, I suppose, as well. But yeah, I think AZ works with practices and dispersal. Pfizer and Moderna don't appear to, but it's ever changing.
Yeah, the only addition to that, Nadeem, is that obviously practices that have been doing clinics for some time may well be at a point where they need to do the second doses of the people that they did initially. And the second dose supply is secure. So if you did patients from your own practices 6, 8, 10 weeks ago, then there is a supply for you to do those patients from your own practices for their second dose. So that activity will be secure and is ongoing, but the opportunity for new AZ clinics is getting tricky.
That's fine. But I think there's still plenty of vaccine available for second doses and dispersal to keep those practices busy. I think that's. Thank you very much, Bhupinder, and for that as well, and our KED colleagues. Is that okay? We'll move on.
I think there was one quick question. I don't know, Kavita, did you your numbers about going forward, and then also I don't know, Wax, you had your hand up whether it was legacy.
I'll put it in the comment, Karen.
Okay. I don't know, Kavita, you were asking about the numbers?
Yeah, no, I just find Accuracy a little bit confusing still, because it's not easy to filter on exactly who's on the list. So we've got about 1,800 to do from 38 upwards. And then I was looking on Accuracy's 522, and I was trying to figure out, okay, who's missing? You know, so I don't know whether that's me. I just can't get my head around it. So I was trying to work out a way of just deleting all of AccuRx and re-uploading one more time again. But then I think that's a bit messy as well. But I don't think there's a delete function for all of you can't batch delete on AccuRx. So I think we're just in a stuck position at the moment. We're going to send out an iPlato, so that might help. But I really wanted to do it on AccuRx so they can book their own appointment. But if anyone's got a solution that comes up, then yeah.
The one of the things with AccuRx is if the patient doesn't have a mobile number, or if that mobile number has failed, you need to follow that up there, because that will be recorded on AccuRx as a manual booking.
Yeah, but I can't see why the discrepancy then.
So what we did was we copied this search across, and you can actually filter out the patients who don't have a mobile number or ones that has failed, and then you can actually, we use doc mail, so we send them a bulk letters, and then we use the bulk read code to read code them, as earlier was mentioned. You use the same SMS read code, but you put a description, letter invite sent with a link, URL link that you would send with the AccuRx message as well, for them to book the appointment. And if they don't have online access, then to call the practice, and we will we kind of supporting them in booking. So I mean, you need to be wary of the patients who not totally rely on AccuRx. You need to be wary of other means to capture these, send the invites to these patients.
Thank you for that. And Max just mentioned the SOP for Pfizer is with NHS London currently, so if it changes, it might allow practice to do some Pfizer. I think that's really it. Thanks for that, Bhupinder. We'll move on to just some updates from NHC. So the first one is Arpana, Vice Chair, and Dr. C.M. Patel's daughter, one of our local GPs, has a baby. Hi, Dr. Patel, are you there? How's the baby doing?
She's doing fine.
And you're helping out, are you?
Mum is doing fine.
That's great. And any pictures you can share with us as well?
I think we have a picture, Nadeem, so Maggie can pop it up. Arpan has been really kind in sharing a beautiful picture.
And any update on the name yet?
Just delightful.
No.
So congratulations.
Thank you.
And if you can pass on those congratulations to Mum and Dad as well. And hopefully we'll see Arpana here back quite soon. We have a couple of updates on Beth, who's our head of operations at NHC and has been running our amazing SLG site and COVAX locally. Unfortunately, she's not going to be with us after this month. So sorry about that. And I think, we've seen your ability and effort you've put into the COVAX program locally. And it's, we really, really appreciate it locally. So thank you, Beth. We're very sad to see you leaving.
You're very welcome.
We're bringing over a cake, Beth, which I'm sure everyone will show you there.
Oh, wow. Brilliant.
Yeah, 100,000 vaccines. I think we hit that yesterday, didn't we, Karen?
Super.
We're hoping to celebrate with Beth and the team just to mark it.
Sure. And as we mentioned earlier, the SLGs has done the most vaccines in all of Northeast London, so that's quite an accomplishment, and it's really helped us locally. So thanks for that, Beth. And also we'll be losing Lena from NHC. Hi, Lena.
Hi, Nadeem.
But luckily we're keeping you local, aren't we? You're going to be moving on to work with John and the Borough-based partnership.
Yeah, so essentially the role I came to do in Newham, which is the integrated care system role, which got paused, let's say, in the interest of promoting all the stuff that we all had to do to react to COVID. That same role is just transferring to ELVF, and we'll be supporting all of the systems. So hopefully very little will change in my day-to-day interaction with my general practice colleagues.
Again, thank you for all you've done, and I think we've all worked with you quite closely with MDTs locally, and thank you both of you really, and best of luck in your in your future jobs. Any questions at all, Karen, or any kind of comments in the chat bar?
I think everyone is thanking Lena and Beth for the tremendous work that they've done, and certainly I'm very grateful that they've been enormously supportive for the first 6 months of my time with Newham, and have helped sort of bring me into the team. But there's a lot of work that everyone can see that Lena and Beth have delivered in terms of Newham. So huge appreciation is the comment.
Big void in NHC that we're going to have to try to fill in the next few weeks. So thank you both from Newham and NHC. I think that's probably it then, Karen. So I think we'll see everyone next month, and we're coming down to SLG anyway. So we'll all see.
Bringing the cake.
Thank you, everyone. See you next month. Bye.
Bye. We're bringing the cake, Beth. So you can actually have a piece. See you in a bit.